Welcome back after lunch, everyone. Was it a good feed? Wasn't too bad, was it? That's good. Coffee could have been better, but yeah, that's right. So we're going to talk about the insertion of CVADs and some of the evidence and issues around insertion of central lines. Around the world, millions of central lines are inserted every year, and you know they're essential for a lot of therapies, but in particular they're used for any medication that's not compatible in the peripheral veins. So anything that's vesicant or irritant or anything that's going to damage the peripheral vessels, we typically insert a central line. And I guess in the last sort of 20 odd years, insertion techniques for central lines have changed significantly, and really they were changing, or they changed to address procedural and infectious complications. So we can get all sorts of central lines now that we can insert, and regardless of the entry point, whether it's peripheral, whether it's the chest, whether it's the neck, if the tip is sitting in the central circulation, then it's deemed to be a central line. And that doesn't matter whether it's a port or a vascath or a PIC line, they're all essentially central lines. And really the choice of what you're going to use, again, is really to do with the patient, the length of dwell, and any other factors that you are predisposed with at the time. So there's different types of lines. Of course, we have Pics, and they have certainly in the last couple of decades really come to the forefront of vascular access. They're typically 40 to 60 centimetres long, predominantly made of polyurethane material, and can be inserted in essentially around the cubital fossa or the brachial vein, so the veins up in the near the bicep muscles. They can occasionally terminate in the inferior vena cava if they're inserted femorally, particularly with paediatric population. And they can have a long dwell. They can be in for a number of months. And in fact, there's reported cases in the United States with Pics have been in for up to 7 years. Your acute central line are typically 15 to 30 centimetres in length, again made of polyurethane. And they're typically inserted either in the axillary, the subclavian, jugular or femoral. Now the axillary vein, we're not talking here, we're talking there, so lateral to the subclavian. So anything from the collarbone back is deemed to be the axillary vein, not the subclavian vein. They typically terminate again in the superior or inferior vena cava, and are more sort of for intermediate or immediate use, and are mainly used in critical care areas. We of course have longer term vascular access devices as well, such as tunneled devices such as Hickman catheters, and they're typically either inserted in the jugular vein or the axillary vein, and they're tunneled subcutaneously. And the main difference with a tunneled line is, and particularly the traditional ones, see how it doesn't have like a wing with holes where you put like a stat lock to secure it in place? That's because subcutaneously there's a cuff that sits under the skin, and over time that granulates and holds that device in place. Long-term catheters like these, after a few months may not necessarily even need a dressing. Again, where they terminate is exactly like any other device, any other central line. And of course they can be in for a number of months to years. We also have high flow catheters, so vascaths, and they're typically used for renal dialysis or apheresis, and they can either be percutaneous or again they can be tunneled. And their insertion sites are typically similar to other devices as well, although you would rarely see these days, because of the issue with thrombosis, you probably wouldn't see many subclavian vascaths because of they take up quite a large volume of that lumen and can predispose the patient to thrombosis. And that's my cat who ended up having dialysis. It's not my cat. Yeah, I don't have that much money. And of course, one of the more longer term type devices are Portacats. And they are implantable devices, so they sit just under the skin, and they have a little reservoir that's connected to the catheter. And They're used typically for intermediate sort of access, and you access the device through subcutaneous tissue. And they've, typically they're devices that are in for quite a long time, for a number of years if required. So CVADs have also changed in that their materials are also different now. We have materials that are both antiseptic or antibiotic impregnated to reduce the risk of catheter colonisation. And when we look at the studies, there's been mixed benefit, but where these types of impregnated catheters are best are in high-risk populations, so hematology, oncology, intensive care. That's where they've shown to have benefit. We also have catheters now which have or are antithrombogenic, and the claim of these types of devices is that they reduce platelet aggregation and reduce extraluminal clot formation and reduction in DVT. And currently there's no strong evidence, but there are studies being done around the world looking at the benefit of these types of devices. And of course, these devices are also power rated. So a power rated device means that you can inject contrast media at quite a high rate, and your risk of intraluminal break is reduced because of the tensile strength of the actual catheter material. So, and typically they'll have it written on the hub somewhere that they're a power rated device. So when we're talking about inserting central lines, some of the things we need to be thinking about is how we can reduce procedural complications and perhaps adopting technology to mitigate that risk. We also need to think about reducing infectious complications through insertion and maintenance bundles, because the catheter-associated bloodstream infection has been shown to increase the patient's risk of mortality and morbidity. And we only have to look in places like intensive care where patients already have organ failure, and if they develop a device-related infection, that could be the thing that tips them over. So it's particularly important that we try and reduce the risk of infection with these types of devices. And here in New South Wales, if there is a CLAB or a central line associated bacteremia, it's reportable to the Ministry of Health. It's given a SAC1, so severity score 1, which means that it requires an RCA, so a root cause analysis. We also want to make sure that when we're inserting these devices that we reduce failure such as occlusion, thrombosis, dislodgement, etc. So some of the things we need to be thinking about then when we're inserting central lines is, well, if we're going to put one in and we're going to go, in the neck, or we're going to go in the chest, it's an issue, of course, with Pics as well, but probably more so when we go centrally, is the patient's coagulation profile. We need to make sure that the patient's not at risk if we accidentally puncture an artery, that we can put digital pressure to be able to tamponade that bleed. Of course, traditionally, when we used to do the traditional subclavian approach, if we were to puncture an artery, it would be difficult sometimes to tamponade that bleed because you've got a clavicle sitting over the top of it. And so patients were at considerable risk of bleeding. We also need to be thinking about allergies and materials, and the materials that we use, and making sure that we're not causing any irritation to the skin, which can as well cause issues with infection. And of course, making sure we're using appropriate skin decontamination techniques. Thinking about, does the patient have a history of thrombosis, and are we going to be putting in a catheter which may predispose that patient to developing some form of DVT? If their medical history, have they had lymph node dissection, so you want to be wary of where you insert it. Again, if they've got any sort of chronic or complex disease, if they've got an elevated glomerular filtration rate, well, we need to be thinking of moving away from using cephalic veins, which may be used later on for fistulas. And also be thinking about the lumens required. If a patient's only needing single therapy, or single medication therapy, then why would we be putting in a double or a triple lumen device when clearly all they need is a single lumen? Some of the other things we need to be thinking about in terms of vessel assessment is, particularly on ultrasound, is that vessel compressible? So part of the vessel assessment is, even if you're doing, let's say for example, you're putting in a pic, you know, you're assessing the compressibility, or you're winking that vessel all the way up from the insertion site into the axilla, up to the axillary vein, checking the jugular vein, looking down towards the brachiocephalic, making sure that when you're inserting that pic, there's going to be nothing there, like no bifurcations, no thrombosis, nothing that is going to impede the advancement of that pic. Think about the proximity of nerves and arteries, and typically, again, this is to do with ultrasound. I'll go through the receiver protocol in a minute. When we're talking about pics, apart from tracking the path, it's been shown that using the basilic vein is probably the best vessel to use for pic insertion. Probably one of the big things, catheter to vessel ratio. And the risk of DVT. There was a review done, or a meta-analysis that was done and was published in The Lancet a couple of years ago, that showed that Pics had a 2.5 times greater risk of DVT than CVCs in patients in ICU. But one of the things that paper didn't talk about was this, catheter to vessel ratio. Now, if you take up half of the internal diameter of a vessel, your chance of thrombosis is over 95%. So one of the things that we like to teach our medical colleagues when they're inserting PIC lines is that just because there's a vessel there doesn't mean you go and put in a triple lumen PIC, because if that vessel is not big enough, you're going to cause a DVT. So and the simplest way to remember is, when you're measuring it on ultrasound, a 3 French PIC needs minimum 3 mil, 4 French 4 mil, 5 French 5 mil, 6 French 6 mil. Very simple, very easy way and quick way to assess whether it's appropriate to use. So, and when we talk about vessel assessment, this is something we use quite often in my hospital when we're inserting our devices, and it's called the rapid assessment of the central veins, and it was developed by the Vascular Access group in Italy, Gavicel. And essentially what it does, it takes you through a step-by-step on how you assess each component of the vasculature where you're going to insert a central venous catheter. So, going from the mid-neck, looking down towards assessing the subclavian artery and the distal internal jugular vein, and there's the valve of the distal jugular vein. Moving across, having a look at the brachiocephalic vein, and that's probably, we'll probably go through that in a minute, but when we do our jugular lines, that's where we do our jugular lines. We don't do them up here, which is the traditional placement point, is sort of mid-neck. And if you see a lot of medical officers still insert their devices mid-neck, you can't put a good dressing on something that's sort of half, hanging out like a Vascath or a central line. At least if you put it with that nice low profile, you can dress it almost like a subclavian, and you're going to get good adherence of the dressing and good securement, and it's less likely to move and get infected. Again, sort of moving across the sternal notch, looking at infraclavicular, and then this is what I mean by an axillary approach. So there's the clavicle, and that's the axillary vein. So you can either go transverse or you can go longitudinal, depending on how deep the vessel is. Skinny people, you'd probably just go transverse because it's quite superficial, but with bigger people, you'd probably look at going in plane, because there's a lot of tissue in between the skin and down to the vessel. So training and procedural load is also important when we're putting in central venous catheters, just like any other clinical procedure. And I guess it really doesn't matter what's your clinical grade, whether you're a nurse or whether you're a doctor. If you've been given the appropriate training and you've done enough, your procedural outcomes are going to be the same. And a hospital here in Sydney, we did a study a few years ago with the CNC that was working in this particular hospital, where basically they run it out of their anaesthetic department. So whoever's available at the time, whether it's the anaesthetic registrar or the CNC, whoever's available does the central line. And we reviewed their data over a period of 18 months. And what we found was that when you look at procedural outcomes, it was basically the same. There was no difference between whether the CNC inserted the line or whether anaesthetic medical staff inserted the line. What was really interesting though was the infectious outcomes, where we found that lines, at this particular time, there were still some wards that were sending their tips off as a regular thing, their catheter tips, and the colonisation rate was much higher in the anaesthetic group. When we looked at catheter-related bloodstream infection, 2.5 per 1,000 catheters in the anaesthetic medical group and 0.4 in the CNC group. So it's not to say that one's better than the other, but it just goes to show that, you know, if you're trained appropriately and you've done enough, your outcomes are going to be similar. So what about other insertion considerations such as ultrasound? Well, that's, I guess, superseded in most hospitals now. It's very rare that you'll see a central line being put in without ultrasound. The only exception to that, I would say, is a subclavian. A lot of medical staff still want to do a traditional subclavian in the event that you know, the ultrasound fails. Outside of that, though, you know, most places will do you know, either a jugular line or an axillary or a femoral. They'll use ultrasound to do that. And certainly, from all the studies that have been done, ultrasound is far superior than the landmark technique in experienced hands. Now, I can tell you, like in my hospital, we teach our doctors to do, you know, central lines, and the last place we let them go with an ultrasound is an axillary line, until we're confident that they can track the needle and they can puncture that vessel and they can see that needle go all the way into the vessel. We just want to make sure, because that's where, even though with ultrasound you're probably more likely to cause a pneumothorax, because you're not tracking your needle and you're losing, you know, sort of perception with the angle of your needle. So overall, though, if it's in trained hands, it will reduce complications, and in fact, it doesn't take any longer than doing a standard procedure. And of course, using ultrasound, you can also assess the once you've finished, you can assess the lung pleura for any pneumothorax. So you look for the sliding lung sign, and you know, there are places in Italy where they use the ultrasound for tip location. So they agitate a bit of saline. So someone's doing a cardiac echo, so they're looking at the atrium. Someone agitates a bit of saline and they flush the catheter, and they look for the bubbling vision in the on ultrasound, and if they can see it, if it's within a second, it's in the right spot. If it's more than a second, it's possibly malpositioned or too high up. If they see it immediately, it's probably in the atrial. So they use that as a quick guide for whether they can and can't use the catheter straight away. So some of the other considerations are, you know, the choice of vessel is really going to depend on what the patient needs, but also the skill of the operator. As I said, you know, you probably want to be thinking of doing this area last until you've got some good training under your belt. Using internal jugular versus subclavian, well, a lot of the studies show that you're less likely to get an infection with a subclavian than an internal jugular. But a lot of these studies are based on traditional methods where they've gone mid-neck and you can't put a good dressing on and the patient gets an infection. There haven't been any studies to show if you insert your device very low profile, so you're able to dress it, whether or not that influences your infection outcomes. Same sort of thing with a subclavian versus axillary approach. And of course, the other thing is, there's a lot of literature to say that, you know, using the femoral as should be your last point, and certainly that's correct for a traditional femoral where you're puncturing near the inguinal groove. What we've started to do is if we can't find anything up here or centrally, we tunnel a pic in the femoral vein. So we puncture up near the femoral vein, but we tunnel halfway down, so the exit point is somewhere halfway on the thigh. And the ones that we've done about 25 so far, and the ICU nurses love it because it's easy to manage. You can put a dressing on it nicely. It's not hanging out anywhere. So we've had a look at the data. We've had no lower extremity DVT, and we've had no infections from those 25 that we've done so far. And we're probably going to write a case series on it. And using insertion bundles is very important. And this is the one, if you worked in ICU, this is the one that Club ICU used to ensure that we tried to reduce the number of infections in the ICUs, and it went down. So basically what they did was they said, well, here's some evidence-based steps that you should use every time you insert a line. You make sure that you use full barrier precautions, sterile gloves, use alcoholic chlorhexidine and so forth. And I think Margie can correct me, but I think it went down from 3.6 per 1,000 catheter days down to approximately 1.2 per 1,000 catheter days for central line infections in New South Wales, simply by using a simple bundle. Oh, 5 minutes, okay. So again, when we're talking about insertion considerations, well, how far should we put this device? Now, when we're inserting, where we want this device to finish is in what we call the cavo-atrial junction. So basically where the superior vena cava meets the right atrium. And the best landmark to use is the tracheal carina. And when we measure off the tracheal carina, 3 to 5 centimetres below the tracheal carina is the optimal spot for where your central line should terminate. And there have been studies that have shown, and there's also been a Cochrane review, that the higher up this catheter terminates, the higher the risk of thrombosis. And in fact, from down here to up here is like a 60% increase in thrombosis risk, particularly if it's coming from the left side, because it's abutting up against the wall and it can cause irritation to the vessel wall. So what we can do is we can try and mitigate some of these risks, and one of the technologies that many PIC teams and central line teams are now using is ECG guidance. So whilst you're inserting the device, you can connect your catheter to an ECG system and pick up the patient's intravascular ECG. And as the catheter's heading towards the cavo-atrial junction, so where it should terminate, anatomically it's opposite the SA node, the pacemaker of the heart. And so the catheter picks up the P wave, and once you have maximal P wave, you are essentially in the spot where you want to be. And there's different types of machines available here in Australia, ones that use magnetism as well, or just straight ECG. And their effect has been quite, it's something like 99 point something % accurate. When we did a systematic review when we looked at the effectiveness of these devices, and they were between 14 and 50 times better than traditional sort of insertion waiting for an X-ray. The problem is, because the confidence intervals or the results were so widespread, it meant that most of these studies were probably, under the sample sizes were probably not as big. So we're currently doing a randomised control trial with this machine here, the Nautilus. So we're randomising patients traditional or using ECG, and we're looking at the clinical and also the financial benefit of these devices. So in summary again, basically it's the same sort of thing, whether it's a PIV or it's a central line. The right trained clinician inserts the right device into the right vessel for the right patient at the right time. Thank you.
Potato challenge was won by table 7. We have some worthy runners-up at 5, 10 and 1. Okay, just moving on now. I'd like to introduce Kerrie. Kerrie is a CNS in day oncology at the Olivia Newton-John Cancer Wellness and Research Centre in Melbourne. It's all right, we're kind to Victorians here. You look after Avatar chapter in Victoria as well, and she's been looking after cannulas for a long time and other devices across the whole spectrum of inpatient, outpatient and community settings. Kerrie's going to be talking about post-insertion care of CVADs, and she's a wanderer, so you're going to have to keep your eye on her.
I stand up here and behave myself, will I?
You can behave yourself whatever you want to do.
No. So be kind to me, I'm a Victorian, okay? So I just wanted to point out, I'm a little bit different than all the other speakers that are here today. I'm a clinician, okay? So I'm an RN working in a clinical area. And basically, I've got a long history in oncology, so that's my background. And I'm tired of actually seeing the poor outcomes that I see in my clinical practice every day of the week. So this is where Avatar has come in, and I've sort of stepped up and basically put my name up just to be the chapter lead in Victoria, because in Victoria we're a tiny bit slower than the rest of the country, I've discovered, at looking and focusing on vascular access. So I turned up to my first meeting with Avatar and went round the table introducing ourselves, and there was a professor here and a professor there and a PhD, and here I said, "Hi, I'm a clinician," and I went, "Yikes." So, and then quietly pipes up Kerrie Curtis, who's head of Avatar, saying, actually, unless what we're doing is relevant to you, what we're doing is pointless. So I thought, actually, there you go. That's sort of an endorsement and to sort of really value that actually clinicians can make an enormous difference. So here is my humble beginning as well. All right, everybody. So I sort of empower you to actually go back to your clinical areas and start asking questions and start being a stirrer, which I've sort of become to know as well. So, okay, now that Evan's put in this fabulous device for me to maintain for up to sometimes weeks and years, I'm just going to be running very briefly through this, because obviously this can take a day in itself, okay, with our maintenance. So there are many maintenance, or there are many different components of maintaining these devices, and there is emerging evidence. We've got a lot of great foundational evidence for insertion. There's a lot more gaps when we're dealing with maintenance of these devices. So we have got some emerging evidence, and we've got a lot of gaps as well. So I'll sort of try and touch on a bit of all of that today, just now. So, okay. Not going. What's the other one here? There we go. So what I like to actually say, and I'm trying to get through to everybody at my organisation, is our actually objective for the removal of these devices is actually due to the end of the treatment, whether it's your long course of antibiotics or whether it's a chemotherapy agent, whether it's a vasopressor in ICU, or any of those sort of indications that we can use, or parenteral nutrition is another good one. We actually want to actually see these devices removed because of the end of treatment, and I can tell you from what I've seen as well, there is sort of a very different picture than what you can see, and these are just clinical photographs I've taken as well. So it is a good aim, but you've got to have that aim there to sort of strive towards to keep us all going. All right, that one's not working. Let's go to that. There we go. Now, like something that Claire talks about with dressings, is there is no one size fits all solution to this. So if you're wanting that sort of, you know, what's that one thing that I can use? Unfortunately, there isn't, because each one of our patients will have a different requirement. Okay, now this can be influenced obviously by a number of factors. So the insertion site, so obviously a dressing on your IJ and on a neck is going to be very different to dressing a groin, or dressing putting a Portacat needle in and dressing onto a lovely flat chest, compared to on the inside of a arm as well. Whether the person is extraordinarily hairy is going to be different than a little cachexic sort of 30 kilogram older lady. So also the frequency of the use, whether you're actually accessing this device on a daily basis or frequently during a shift, or whether you're actually just in between treatments like we can have. They'd be sort of 4 to 6 weeks in between actually accessing these devices. And obviously the patient cohort as well. So the dressings for a paediatric patient will obviously be very different to an adult. So let's have a look at what we're actually dressing them with. So our dressing materials here. And I come along, rather than looking at all the different, doing the systematic reviews myself, I look at very closely to our colleagues here in Australia, a lot of them, with our Cochrane collaboration, our Cochrane reviews as well. So what have we got with our dressing materials? Well, we have some pretty good evidence actually in regards to CHD impregnated dressings with our central lines, and they actually found that they do reduce the frequency of the catheter-associated bloodstream infections. This series of trials that they reviewed were mainly in the ICU. All right, and that's a lot of the evidence that we have with maintenance is in the ICU. Whether you can sort of take that to other areas once again is sort of something we can look forward to in the future. But once again, there was decent evidence and high quality evidence in some sort of medication impregnated dressing. So I know EPIC 3, the UK guidelines, as was mentioned earlier, had an additional publication they put out last year to actually include the CHD gel pad dressing, which actually has the actual gel included in the actual dressing material itself, which is this one up here. So there seems to be fairly good evidence in regards to some sort of medicated dressing components actually improving our infection rates associated with these lines. So if you actually have a look in the implication for us in the clinical setting is that if you have one of these, and it's still, if you sort of get to this stage of actually having a systemic infection from one of these, the devices, it's still conservatively costed at about $38,000 per infection. So when you sort of looked, and we implemented this gel dressing in our organisation, they're saying, well, it's actually sort of quite a, costly piece, if you have a look at the individual price of but if you actually look at that and how much, implementing that dressing would be actually on how much it would prevent with the central line, you can sort of see, you can sort of see the benefits of that original implementation of that material. So this is what we've got with as well. We've also I was speaking to some colleagues earlier in the year at another conference, and we have we always have the implementation or the introduction of new materials as well. So I'm fortunate enough in a clinical setting to actually see we organisationally implemented as a CHD impregnated dressing. And I sort of have the benefit as a clinician to actually see where the patients where that work, and also the patients where that is not so fantastic outcome for them. So this is where no one sort of size fits all principle comes in place. We, for example, with the gel dressing that we have implemented, I've also come to see here, as we can see just in this circle here, a dressing reaction. So for this particular person, this CHG dressing wasn't a successful outcome for them, and we needed to change that dressing. So even though we have got the evidence of a CHG impregnated dressing or a foam patch, for this particular patient it didn't work. So you always need that alternative, or that second line alternative for your patient. I must admit, in oncology, we tend to sort of tip in the high risk. I think that'd be fairly well sort of agreed with when I've been talking to other oncology nurses in the room. Seem to sort of tip into one of the highest risk patient cohorts. So we do need alternatives, and then this is where more research and more just one clinician to sort of say, actually, I'm really interested in this particular area. Let's actually have a look and see if there's an alternative. Let's see if we can sort of implement or trial new products that are actually out in the market. So what have we got for dressing frequency? Well, here we've got a systematic review in regards to frequent dressings, and unfortunately, there is it's still inconclusive with the trials that they put together for this particular review. Keep on hitting the wrong thing. So in regards to dressing frequently, unfortunately, we still are a bit up in the air. Anywhere between 2 and 15 days, the trials that they included, and the RCTs they included in this systematic review, there was a wide range of dressing frequency. So we're still a little bit in the dark in regards to that. But they did go fantastically on for me, being a clinician. What does that mean for me in the practical setting? Is that we still need to inspect our CVAD dressings and sites every day, so on a daily basis, to make sure that they're clean and they're intact as well. And then also to clinically indicated to actually remove them or replace the dressings, I beg your pardon, when it's clinically indicated. All right. So actually I did, this systematic review I spoke about earlier, this actually I did choose to actually pull Securement out and actually mention it independently, because it is a very much a not so focused on area. We either have infections right up there, but Securement of a device is pivotally important as well, whether it is with sutures, which we've traditionally used for our CVCs, adhesive devices, tissue adhesive, a novel alternative that we see to have emerging, or whether it's now it can be also an actual securement feature of the dressing. So what they actually found in this systematic review was that actually it was the sutureless securement device that was the most effective at actually reducing the incident rate of the catheter-associated bloodstream infection, rather than this. And secondly, was the actual sort of antimicrobial dressing or dressing components. So once again, you can't underestimate the effectiveness and the importance of securing your device, whether it is with any of those combinations of those securement features. So this is where we look to research to sort of say actually what is the most effective way of securing a line, and we look at our colleagues in Brisbane, and I keep on stalking these guys and asking them information. So very, very useful resource to have. They've got their Pics trial in recruitment stage still at the moment, but they're expecting, and they're looking at PIC lines and securing of PIC lines, and they're expecting to actually to halve the catheter-associated bloodstream infections. So that is something that I in oncology, actually really look forward to seeing the results with that, so I can actually take it back to my area and start sort of at least have something in paper that, and with sort of good quality evidence that I can go back and say actually we need to look at this and look at that in our practical setting. Also, we've got the Cascade Trial. So there's four arms of this, with the three experimental groups and then a control as well, and they're looking at the difference that on the failure rate of the Securement device, and there's 6 different areas that this is in different stages. There one arm of the trial, an adult ICU, that was published last year in 2016, so all our counterparts here in ICU, and they found an innovative solution of a suture and tissue adhesive with just the simple polyurethane dressing appeared to have a really positive outcome, in that they had 0 CVAD failure observed within their trial. There's another 3 arms that actually have been submitted for publishing that we can all look forward to reading shortly. And there are another 2 arms of that trial that actually is in the recruitment stage. So once again, while we don't have a lot of evidence, we've got some evidence there, we've still got a lot that are being currently underway, and we can look forward to seeing the results. So skin antisepsis, it's quite interesting in regards to skin antisepsis. I thought that was sort of a no-brainer with sort of what the evidence we have out at the moment. So we have this systematic review here, and that was done in 2016. And it was 12, and they were reviewing 12 studies with over 3,400 adult CVCs that were assessed in a variety of different settings, and it basically showed that the strongest that they came back was the skin antisepsis with CHG may reduce the catheter colonisation relative to the povidone iodine. However, the quality of evidence for that was fairly low. So they were saying it was still inconclusive, and appears that more RCTs are needed. So I sort of came across we used the EPIC 3, and we're talking about the EPIC 3 guidelines before, and looked at their recommendations. And I recently was involved with a group that actually had a look at all the worldwide sort of recommendations rather than RCTs, looked at the recommendations. And when we reviewed with the CNSA the EPIC 3 guidelines, it actually was fairly solidly reviewed and had a lot of quality, what would you say, methodology in their systematic review. So I looked at this, and once again, they actually made a Class A recommendation. So this was their highest level of recommendation here, that you actually, the 2% chlorhexidine in 70% IPA alcohol was the preferred agent and recommendation for maintenance therapy as well in maintaining our devices. I think I've swapped, or sort of moved past the swabbing, scrub the hub. I think there's been a lot of discussion about scrub the hub and whatnot. So something that's piquing my interest are these passive disinfection caps. I've got a particular high risk patient cohort of our bone marrow transplant patients, and once again, they were the last patient cohort that we had that actually sort of bringing down our Staph aureus bacteremias in our organisation. So whether this actually would be a helpful introduction in this sort of particular cohort. So then I started to have a look around at the evidence that we've got in regards to the passive disinfection cap, and came across Nancy Moreau's review with Julie Flynn, one of our colleagues here in Brisbane. And basically their recommendations here was, once again, comply with the standard, which of scrub the hub, whether it's your 15 seconds, 30 seconds, 60 seconds, and according to your organisational sort of policies, but also to facilitate education. So actually sort of say what the consequences are if you don't do an adequate scrubbing of the hub. But then also to actually consider the use of passive alcohol disinfection caps in particular patient cohorts. 5 minutes, thank you. Flushing and locking. It was interesting. I went to one of the World Congresses recently, and I went to a lecture singing, and they were talking about this and looking at all the guidelines, and I went, right, give me that one locking solution that does everything. Keeps it patent, it reduces the risk of infection, and unfortunately they said there is still a lot of inconsistencies, and there is still a fairly it's inconclusive still in regards to the flushing and locking. So because we have got this saline heparin sort of debate still happening, and we've got a Cochrane review here in regards to that actually showed that there was no conclusive evidence in efficacy or safety that heparin was any better than saline. So it's associated with the costs of heparin and also the complications of heparin, whether it would actually be safer then to just use saline. So in regards to that as well, we've also got our novel flushing and locking with our citric the citrate and also the Toradin as well. So, and this was the particular lecture I went on to. I said, right, okay, there are different concentrations and there are different combinations. And once again, unfortunately, one of the world experts who was talking about that says there is still an inconsistency about what percentages and what combinations of those two devices, or the new novel, to actually sort of implement it and actually make recommendations at this stage. And there is a lot more research that's needed, unfortunately. So once again, I couldn't sort of bring that back, but once again sort of at least raise that if we've got a particularly high cohort of patients that have got a high risk of infection, whether that might be something that as a clinician you might be interested in, and actually then sort of take it back and say, hey, can we start looking at something like this? So also something, an area that I've picked up through my stats is actually whether there was any evidence on how we actually restore these catheters if we get a blockage and we get a thrombotic occlusion. So basically with that, they said there was fairly inadequate evidence to draw a strong recommendation or for that, but they actually said there was two particular agents they looked at in this systematic review, the urokinase in varying strength and the alteplase 2 milligrams per mil, may be effective in treating the withdrawal thrombotic occlusion, and that there were novel blocking agents we've got emerging evidence. So they certainly are still in the mix as well. So just looking back in summary, I'm just finishing now. While we have got some gaps in maintenance therapy, we still have got some not everything will be an RCT, our pivotal sort of systematic review and RCTs, but we have got varying levels of evidence that we can at least start the conversations and go back into our home units and start raising and just asking questions would be a good start. So actually we have got some evidence that there's, CHG might be a great addition, or if we're just using alcohol for swabbing our needleless connectors, or there is, fairly strong evidence to say that actually some sort of medication impregnated dressing may be beneficial. So I just wanted to say thank you and just leave you with a message that we are all clinicians, and if there is something in your clinical area that you think, oh, that's interesting, start as a clinician. We can do it. If I'm sort of starting this sort of process and whatnot, I empower and I challenge you to sort of go back into your workplace and do the same. Thank you. Yeah, I threw your mouse away.
Thanks, Trish. That was great. Right, next lot of group work. Okay, we're just running a bit late, so we're going to change this round a little bit. So this now, let's talk about solutions to implementing new practices in your local setting. Things that you've implemented yourself or have been part of you thought were worthwhile, actually made a difference. So just spend about 5 minutes writing down some stuff that you've found useful, education, flashcards, lanyard cards, all those sorts of things that you feel were useful. Provide a little bit of context around them. Then just get back together as a group and write the list down. And then at the very end, I'm going to ask you to write down your top 5 that you felt were most useful, and then I want those cards to come back to me. I'll get you to write that top 5 on some post-it notes that are on your table, and I'll get the facilitators to bring round a piece of paper for you to write on in a sec. So the thing on your table is for your top 5, not for your brainstorming. Okay?